Hello, my name is Ariostos Silva. I'm an associate member at the Department of Cancer Physiology at Moffitt Cancer Center. Today we'll present you EMA, the ex vivo mathematical hematologic malignancy advisor. It's a tool we have developed to help treat patients with multiple myeloma. Multiple myeloma is a treatable yet incurable cancer of the bone marrow. So uh, every year we have 32,000 more new cases in the United States, about 12,000 deaths, and about 141,000 live patients. Today, every patient has an estimate 50% 5-year survival. And while these patients respond well to initial therapy, the tumor develops resistance. So treatment of multiple myeloma consists of multiple cycles of response and development of resistance and thus relapse. Our challenge here is how can we find the best regimen, the best combination of drugs for each patient at every moment in time? So this is our first application of this tool, where we actually would like to determine for each patient the best therapy possible for them. The implementation is essentially we collect cancer cells from bone marrow aspirates in standard of care biopsies. These cancer cells are co-cultured in multi-well plates, 384 or 1536 well plates, where we are reconstructing the bone marrow microenvironment. So there is stroma, there is matrix, there are patient-derived soluble factors from blood plasma. And we longitudinally image these cells across 6 days, and we use a digital image analysis algorithm to detect live and death. So it's a non-destructive assay. And the idea is that it produces enough data points, enough detailed information that allows us to actually infer intratumoral heterogeneity of drug sensitivity. And this intratumoral heterogeneity is used to parameterize mathematical models. These mathematical models are patient and drug specific and can be combined with pharmacokinetic data from clinical trials to create patient-specific predictions of therapy response. So you can create patient-specific clinical trials, right? In silico clinical trials. We have published these in multiple myeloma, but also in mantle cell lymphoma. So it's a generalizable tool. And we also create for every patient who consents to provide this biopsy for research here at Moffitt, an automated report that's reviewed at tumor board. This report basically says for each patient which would be the best drugs and drug combinations predicted by the model that would give the best response for each patient. This also allows you to compare that particular patient with all other patients we have tested in our assay to give an idea of where the patient sits in terms of distribution of response. A second application of this device is as a drug screening tool. So the idea is you can create in silico clinical trials by screening a cohort of myeloma patients with a list of experimental drugs, and you can predict or estimate how this new drug would compare both as single agent and as in combination with standard of care. It would allow you also develop inclusion exclusion criteria for your actual clinical trial. So we have tested multiple different classes of drugs from standard chemotherapy to targeted therapies and immunological therapies as well. Another aspect of these two is that you can also assess synergy, but in a clinical level, in other words, take into account the different pharmacokinetics of different drugs. And it allows to actually estimate the clinical synergy of drug combinations. Today, this is developed and conducted at our laboratory at the Moffitt Cancer Center, where we consist of 9 digital image analysis microscopes, each one running one plate, so one patient, with between 31 and 127 different drugs. And the drugging, the seeding, everything is automated using plate handlers, both 384 and 1536 well plate handlers. And this tool also moves forward by integrating molecular data like RNA-seq and whole exome sequencing, with using a gene set enrichment analysis and other systems biology tools. We can also infer mechanisms of resistance and sensitivity to different drugs. and then make an inference on optimal combination therapies, right, to resensitize refractory patients to standard of care therapies. So again, thank you for your time. This is our contact, and we will gladly answer any questions. Thank you.